Okay, we have some people joining.
Do you want to move it?
No, that's fine.
Okay, I'll just wait a few seconds for some more people to join, and then I'll make a start. Okay. All right. So, hi everyone. Thank you for joining us today. My name is Gabby, and I am the educational lead at SUPTA. This week, we will be focusing on ophthalmology, specifically blurred vision. I'm really excited to have you all with us. Today, I am joined by Kerem and Tim, who are both final year medical students at Plymouth University. To make the session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we really encourage you to participate actively. There aren't that many people on the session today, so please don't be embarrassed at all about getting the answers wrong. It's purely for your learning. At the end of the session, we'll share a feedback form. If you complete this, you'll receive a certificate of attendance and exclusive discount codes for Teach Me Surgery past the MRCS. Additionally, this session is being recorded. The recording and slides will be shared on our medal page in a couple of hours after the session, so please keep an eye out for that. We're also excited to share that an exclusive question bank and other resources will be available on our learning portal, so please be sure to check out our website to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off Geeky Medics Anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code that we'll provide. The more sessions you attend, the higher your chances of winning, so please be sure to stay until the end of today's session and attend our other sessions as well. We'd also like to thank our partners, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the CS. Finally, we have a quick announcement. So this teaching series is coming to a close soon, and after our final week on pediatric surgery, we will still be on medal. We'll be moving all our future sessions to career book. This includes our upcoming national conference and series focused on preparing you for foundation year 1, which we'll be really looking forward to. So keep an eye out on our socials for any updates and to keep you guys in the loop. And then without further ado, I want to hand it over to Kerem and Tim.
Perfect, thank you very much. So I'm just going to quickly share my slides again because they stopped working briefly. There we go. Can you see that?
Yes, we can see them. Perfect.
Okay. So today's session is on blurred vision. There's a couple of different pathologies and things we'll be covering. And my name's Kerem. I'm one of the tutors for today. And we've got Tim as well.
Hi, my name's Tim.
I'm going to be sharing this PowerPoint and discussing different sections together. So thank you to our partners again, the list there. And for today's learning objectives, we're going to understand the anatomy of the vitreous humor and the retina, including its layers and the neurovasculature that supplies it. We're going to also explain the anatomy of the optic nerve as it enters the orbit and the vasculature that runs along it to supply the retina. We're going to describe the presentations of pathologies in this vasculature, and that includes things like diabetes and its associated retinopathy, central retinal artery occlusions and vein occlusions, And there's a couple of other presentations that we're going to look at. These include retinal detachment, vitreous hemorrhage, ARMD, which we'll talk a bit more about later, glaucoma, and hypertensive retinopathy as well. And we'll talk a bit about the management of these acute and chronic conditions. We're going to also describe the importance of the red reflex in infants, and as you might know, that relates to retinoblastoma, so we'll talk a bit about that as well. And we're going to understand the pathophysiology, risk factors, diagnosis, and management of cataracts, including some of its post-operative care and why that's important. So the vitreous humor is a sort of colorless gel-like substance that fills the space between the lens and the retina, and it's also known as sort of the posterior chamber, or vitreous chamber is essentially what it fills up as well. That's the other terms that you might hear that are related to it. It's composed mostly of water, along some sort of collagen, sugars, or electrolytes and proteins and things like that. So not too important, that aspect of it, but it does have an important role, and it has a couple of roles actually. The main one would be sort of maintaining the round shape of the eye from the inside, so keeping it the shape that it is. But it also helps with vision clarity and light transmission to the retina. It also helps absorb any unexpected disturbances or trauma. So if you do get trauma to the eye, this fluid can help absorb that. It supports the lens as well, so it pushes the lens and keeps it in place. And it also holds the layers of the retina in place as well. So it pushes the lens forward at the front and then pushes the retina at the back, so it keeps everything where it's supposed to be. When it comes to the retina, it's essentially the very back of the eye, and the innermost layer of the eye is the retina, and it's used for essentially picking up images that you'll see with your eyes, because it detects light essentially. And it's composed of sort of two layers, the pigmented outer layer and the neural inner layer, which you can see on the top left diagram there. The pigmented layer is formed by a single layer of cells attached to the choroid, and it supports the choroid in absorbing light. It does continue around the sort of whole inner surface of the eye, as you can see on that top left image again, which the other layer, the neural layer, doesn't, and we'll talk a bit more about that now. So the neural layer consists of the photoreceptors, which you'll be aware of, your sort of cones and rods and different cells that are involved in that. And they essentially detect light. So that is essentially why it's called the neural layer, because it detects signals. And as I was saying before, unlike the pigmented layer, this does not cover the whole of the inner eye surface. It's often referred to as the optic part of the retina. So you might hear that term thrown around sometimes. And this is what's seen during ophthalmoscopy as well. So you can't actually see the outer parts of the pigmented layer. You can only see this section of the retina when you do ophthalmoscopy. And at the center of the retina is the macula, which is a yellow and highly pigmented area. And this contains a depression called the fovea centralis. For anyone that doesn't know what the fovea centralis is, it's essentially a really high concentration of light detecting cells, and is thus responsible for high acuity vision, so the most important part of your vision. There is another important structure which you can see on the diagram on the bottom left, and that is the optic disc. Essentially what this is where the optic nerve enters the retina, and thus it doesn't actually have any light detecting cells. So you can actually test for this when you test for your blind spot, because that part of the eye can't actually pick up any images. So your brain kind of tricks you in some ways to fill that gap. When it comes to neurovasculature of the retina, it's not actually too complex. I know that image there does look a bit overwhelming at first, but there are only a few important arteries and veins to be aware of. And the eyeball itself receives most of its arterial supply via the ophthalmic artery, which branches off the internal carotid and divides into many different branches. And that includes the central retinal artery, which supplies the internal surface of the retina, and therefore occlusion of that artery will quickly result in blindness. But there's also the anterior and posterior ciliary arteries, which make up the choroidal vascular system and supplies the outer part of the retina as well. When it comes to venous drainage of the eyeball, this is carried out by the superior and inferior ophthalmic veins, which essentially just drain into the cavernous sinus at some point. And as you can see in the image in front of you, the optic disc is not the only location where the optic nerve meets the retina, because it's also really important for the vasculature as well. So that's the most important thing. Your actual optic nerve leaving via the optic disc, but also your veins and your arteries do moving through the optic disc as well. So the optic nerve, it has a complicated route to transmit information from the retina to the brain. And this does start at the retina, where signals are transmitted via ganglion cells whose axons essentially form the optic nerve, which you will have seen in the previous images before. The optic nerve from each eye converges at the optic chiasm, which is located at the base of the brain. And here, fibers from the nasal or inner portions of your retina, which eventually, of course, form the optic nerve, cross over to the opposite side, while fibers from the nasal part of your eye cross over, it's important to realize that the temporal or outer part of these nerves do not cross over, and they remain on the opposite sides. From the optic chiasm, the fibers continue as the optic tracts, and these tracts pass around the lateral surface of the midbrain. But before reaching the brainstem, which I'm going to talk a little bit more about in a second, the optic nerve has to first exit the eye socket through the optic canal, as we can see in the image on the bottom right and partially the bottom left as well. But the bottom right is the bony surfaces which show the optic canal. The optic canal transmits each optic nerve from the orbit to the cranial cavity, providing the pathway for visual information to travel towards the brain. And the optic canal also transmits the ophthalmic artery as well, which is really important, because if you get swelling anywhere around the optic nerve, you're also going to potentially lose your blood supply, or an important aspect of your blood supply, to your eye as well. And the optic tracts, like I was going to continue talking about before, then project onto your lateral geniculate nucleus in the thalamus, where signals are processed and then organized before they're sent further afield via the optic radiations to other parts of your brain. And obviously that's mostly the posterior part of your brain, where all your optic information is processed and turned into images, essentially. So we're going to talk a bit about pathology now that we've done with our anatomy and a little bit of physiology lesson, because I'm sure that's what you're all here for. And we're going to start off by talking about retinal detachment. So retinal detachment is the separation of that neurosensory layer that I was talking about before, which is the bottom layer of the retina, from the retinal pigment epithelium, so that's pigmented layer of the retina. And it's often a result of age-related retinal thinning and vitreous humor shrinking. And because of these two processes, which are related to age, it does happen, that can cause a tear in the retina. The other potential cause is trauma. It's not as common. I thought it was an issue before I read up on it, but it's actually this age-related process that's the most common cause of retinal detachment. When it comes to symptoms, the classic things are things like floaters, your flashes, so your photopsia is the other name for flashes, and you won't have any pain per se. You shouldn't normally have pain, but you will get this progressive reduction in your visual acuity, and it's usually your peripheral vision first. If the detachment does progress to the macula, which, as we were talking about before, is an area of really high concentration of your neural cells, so it's really important for your vision, then essentially you could actually irreversibly lose your sight, which is quite severe, and so we want to do something about this before that happens. There are investigations to do. Fundoscopy is a really important one to do early on, so you want to visually inspect the back of the eye and view the detachment. You also want to do ultrasound as well to get a detailed image of the eye itself. And there are a couple of other tests you can do as well. So that might be things like optical coherence tomography, but not going to talk too much about that today because that's more specialist. So yeah, initially you want to do sort of fundoscopy to view the actual retinal attachment. That's about as much information as you need to know early on. When it comes to management, I'm not sure why the text is sort of moved into the images, but if the macula remains attached, there should be really, really significant urgency to save your vision, because as soon as that macula gets ripped off, essentially, you're going to lose pretty much all your vision. So we want to save your vision before that happens. And there are a lot of options to do that. The main ones we talk about today is laser therapy or cryotherapy, and essentially it just seals the retinal tears or holes in your retina. So that's one option. There is also a vitrectomy, which removes vitreous humor and replaces it with a gas bubble or silicone to try and stop that tearing from continuing. And there are a couple of other options, but they're the main two that I think are probably important to discuss. Ooh. So, vitreous hemorrhage. What is it? Well, it's basically what it sounds like, essentially. It's blood within the vitreous humor, and this can occur due to a rupture of blood vessels within the eye. There are some symptoms associated with this which are quite classical of this sort of presentation, and that includes blurred vision because of the blood in the eye, sort of covering up those cells that should be detecting your vision, or the light going onto the retina, but instead, for whatever reason, there's now blood in the eye, so you can't do that. And there'll be floaters as well, so dark spots you might notice in your vision because of the blood. And it shouldn't be painless. Well, it should be painless, sorry, but you will unfortunately get sort of loss of visual acuity as well. In terms of investigations, fairly similar to start off with. So you want to do fundoscopy to have a look inside the eye. Slit lamp is also really important. And essentially what we're doing with both of these two things here is essentially looking for the hemorrhage. So if we can see blood in the eye, we can pretty much tell that this is a vitreous hemorrhage. And we can tell because we can look at the back of the eye and see if there's any blood there where it shouldn't be. Some of the things which we did mention before, so your optical coherence tomography is another option. The other things, a bit too far or a bit too advanced to maybe discuss today, but one important thing to be aware of is your orbital CT, because if someone has a hemorrhage in the eye, you might also want to consider if they've got orbital trauma causing bleeding elsewhere, or other problems you might want to be aware of, such as fractures to the base of the orbit, to any other the bones of the face, those sort of things you might want to think about. In terms of management options, if the hemorrhage is small, you might not need to do anything. You could just observe them. That is an option with vitreous hemorrhage, even though it does seem quite severe for the patient. That can be quite a difficult conversation to have, actually. But if we think about it from a surgical point of view, we might do a vitrectomy, which is essentially removing part of the vitreous, because that might either stop the bleeding or get removed some of the blood from the eye to try and resolve this. But of course, we're going to be thinking about managing underlying causes, and as Tim's going to talk about shortly, we will essentially be talking about diabetic retinopathy and some other vascular conditions of the eye which are related to this. So we're now going to move on to our polls, which I'm going to just quickly go on to this slide here. Oh, Gary's
I'm
there.
ready for the polls.
Perfect.
Okay. So I'll release the first one. Do you want to read it out?
Yeah. So which of the following is not a recognized role of the vitreous humor of the eye? And the options are focusing light onto the retina, absorbing mechanical shock or trauma, maintains the spherical shape of the eye, and helps stabilize the position of the retina.
So guys, I really encourage you to participate. There aren't that many people on here, so please don't be worried about getting the question wrong. Well done for everyone who's done submitted a response so far. Also, there's a question in the chat. What is slit lamp versus fundoscopy?
Yeah. So your slit lamp is essentially like a microscope that can be used to sort of magnify and look inside of the eye, and particularly look at your anterior and posterior chambers. Whereas the other one was fundoscopy. Fundoscopy is more like your ophthalmoscopy essentially. So slightly different, but the purposes of both of them, while they are similar in terms of looking at parts of the eye, they do look in different ways, if that makes sense.
I'd also just add the slit lamp is like you want to specifically look at the cornea and you're looking for any damage on the cornea and you can use staining. Whereas fundoscopy, you're trying to visualize the back of the eye. So like the blood vessels, the optic disc, the macula and things like that.
Yeah.
Okay, so I'll end the poll now.
Perfect. So most of the answers there, most people selected A, which is correct. So it's essentially, while the vitreous humor may have some slight refractive properties, it's not a major contributor to focusing light on the retina, unlike your sort of lens and your cornea would. So that's why A is the correct answer, because it's incorrect. The other answers, so absorbing any unexpected disturbance of trauma, maintaining the round shape of the eye, holding the layers of the retina in place, and also holding the lens in its place as well, they are all correct. Okay. So, question 2.
So the poll is now live.
So, which of the following is not a typical symptom of retinal detachment? And your options are photopsia, reduced visual acuity, pain, and floaters.
Good responses, guys. Keep them coming. Okay, I'll end the poll there.
Perfect. So most people have selected pain, and that is the correct answer. Yeah, retinal detachment isn't usually painful, so that's why that's correct. Whereas the other options on there can all be a symptom of retinal detachment, so that's why the correct answer is pain, because it should be painless. Okay, so continuing on, I'm going to switch out for Tim now. So Tim's now going to continue the presentation.
I'll just scoot into the frame. Oh yeah, so I'm just going to continue talking about some more pathology, and we're going to start off with diabetic retinopathy. First fact about this pathology is it's the most common cause of blindness. And then just talking a bit about the pathophys, how does it occur? So with poor diabetic control, you're going to get hyperglycemia, and that causes microvascular damage. And of course, you have some microvasculature in the eye, which Karen told you about a few moments ago. So high blood glucose leads to various changes in the retinal blood vessels. And then on the flow chart, you can see up there, you've got some basement membrane thickening. So the walls of the blood vessels will become thicker and then less permeable, so less functional as well. You're going to get some inflammation and oxidative stress. So inflammatory cells and molecules are going to contribute to the breakdown of the blood-retinal barrier, and that's going to allow fluid to leak into the retina, which is not going to help with your vision. Then you're going to get some neovascularization. So because of hypoxia and VEGF in response to capillary non-perfusion and retinal ischemia, you're going to release vascular endothelial growth factor, and that stimulates the growth of new abnormal blood vessels. So not the blood vessels that would provide a functional use for the eye. And those blood vessels are more leaky and often fragile in comparison to the regular ones that you need to supply your eye with oxygen. Then you're going to get neurodegeneration, and that's going to result in retinal, neuronal, and glial cell damage. So the damage to the retina's blood supply, the blood vessels also affects the retinal neurons and glial cells, which further contribute to vision loss. The symptoms that you get with diabetic retinopathy, the early signs might not even be not noticeable. So constant checkups and ophthalmoscopy is important. But the early symptoms you can get are floaters and difficulty seeing in the dark. So just very vague sort of vision symptoms. And then as it progresses, you can get blurry vision, as the title of our presentation, sudden vision loss, and just outright blindness. It's sort of graded in non-proliferative and proliferative diabetic retinopathy. And non-proliferative can be graded from mild to severe. So it's like a table of things that you want to include in the definitions. But in mild, you sort of get one or more microaneurysm. And then in moderate, you get some blot hemorrhages, some hard exudates, and some cotton wool spots. And I'll show you a slide about this in a second. And then in proliferative, this is like very late stage diabetic retinopathy. You're going to get the neovascularization, which can lead to vitreous hemorrhage, as Karen talked about earlier. You're going to get some fibrous tissue forming on the anterior part of the retinal disc. And proliferative diabetic retinopathy, it's quite serious, and it's more common in type 1. And people that develop it will have a 50% chance of becoming blind in 5 years. So what's the management for this? Well, essentially, it's diabetic control. So once you notice non-proliferative diabetic retinopathy, the best thing to do is closely monitor the eye function and then monitor diabetic control as well. So make sure they're checking their glucose and compliant with their treatment. For proliferative, we've got some options. So we've got panretinal photocoagulation. This is just a laser that sort of treats the eye and controls the neovascularization. Then anti-VEGF medications also do a similar thing, and it's delivered through a intravitreal injection. And surgery, which is just vitrectomy, can be used in like very severe cases. And then in that instance, you can, sorry, not in that instance, but you can also use an intravitreal implant, which contains dexamethasone, and that will just help with some of the macular edema, which can develop. So this is a slide that's just showing some of the key things you might see on ophthalmoscopy. So in the top left, you can see the hemorrhages. They're defined by the small little red blotches. If I can convince you that they're there on the slide, I can barely see the bottom two, but the top one there. And then on the B slide, we've got microaneurysms or hemorrhages as well. And then the cotton wool spots start appearing. So these are the sort of whiter spots there in the bottom right. And then they just represent like bundles of nerve being damaged. Hard exudates as well there in the bottom left. And then you can see the neovascularization starting to form. They're quite irregular, quite thin, and they sort of start centrally, and then you'll see them spreading towards the edges. And then on the bottom right, we've just got another photo of some of those things there. Okay, next we're going to talk about central retinal artery occlusion. And the main symptom that you want to take away from this is sudden painless loss of vision and RAPD, relevant afferent pupillary defect. So central retinal artery occlusion occurs when there is an occlusion or obstruction to blood flow through the central artery. So that's the one that's going to sort of branch out and supply the whole eye. And it's a branch of the ophthalmic artery, which is also a branch of the internal carotid artery. So the most common cause of central retinal artery occlusion is atherosclerosis, just a very common cause of your arteries becoming narrow. However, it can also be caused by sort of inflammatory vascular diseases like giant cell arteritis, but it's mostly atherosclerosis. So risk factors are obviously going to be cardiovascular disease, things like smoking, hypertension, diabetes, raised cholesterol, just anything that sort of increases the risk of atherosclerosis. And in terms of giant cell arteritis, you're going to get the risk factors for that, which are things like white ethnicity, older age, being female, and polymyalgia rheumatica. With this one, you also get a sort of curtain coming down effect, which can be quite confusing, but you can differentiate from some other pathologies because there will be a relative afferent pupillary defect. And then just a reminder of what this is, it's where the pupil in the affected eye will constrict more when light is shone into the other eye. So that's because the affected eye, let's say the left one, is not going to sense the direct light reflex because there's ischemia there. So the only way that it's going to be able to contract properly is if the healthy eye, let's say the right eye, is sensing the light, and then there's only the consensual light reflex. So that's why you have the relevant afferent pupillary defect. And then the most common sort of buzzword exam thing that you're going to see on ophthalmoscopy is the cherry red spot, and it's in the fovea, which is the center of the macula, and it's spared by choroidal circulation, which sort of supplies the whole outer retina. And then because the surrounding retina is opaque, you get this characteristic cherry red spot. It's kind of hard to miss, and then you'll see this very pale retina on ophthalmoscopy. In terms of management, we've got a few options. So it's a vision-threatening emergency. You really want to refer immediately. It's not really something you deal with as like an F1. And as soon as you get this treated, the sooner you get it treated, the better, as there's a really serious risk of blindness. If giant cell arteritis is the cause, you also want to do some testing, so some ESR and temporal artery biopsy. And then, as you know, those are done first with steroids before the biopsy. Then you can do some sort of immediate measures, ocular massage, massaging the eye. This will reduce the intraocular pressure, as well as anterior chamber paracentesis. And this is just removing fluid from the outer anterior chamber to reduce intraocular pressure and really trying to reduce your chances of becoming blind. Then you've got some artery dilation techniques. So these include inhaled carbogen, which is 5% carbon dioxide, 95% oxygen. Then you've got sublingual isoboride dinitrate, which is just a nitrate that dilates the artery. An oral pentoxyphylline, I hope I'm saying that right, which also does the same thing. Then you can also reduce intraocular pressure further with some intravenous treatments there and topical timolol. For long-term management, so sort of prevent relapse of this occurring, is you really want to treat their cardiovascular risk factors. And that's pretty much the best way to prevent that, unless, of course, they have vasculitis type picture. Then we have central retinal vein occlusion. So similar thing, but to do with the veins. And instead of atherosclerotic sort of progression, you're going to have formation of a thrombus in the retinal veins. And then this is also going to cause painless blurred vision and vision loss. This is also an emergency, so refer your cases immediately as soon as you see them. And so when the thrombus forms in central retinal vein occlusion, it's blocking the drainage of blood from the retina. And there's three things that contribute to this thrombus sort of forming. So you have venous stasis, endothelial damage, and any condition that increases coagulability. So let's talk about the risk factors for central retinal vein occlusion. So we're going to have things like hypertension, high cholesterol, diabetes, smoking, high plasma viscosity, like anything that causes that, such as myeloma, myeloproliferative disorders, inflammatory conditions as well, like SLE. Right, so how it presents is retinal vein occlusion causes painless and blurred vision loss, as it says at the top of the slide. This usually affects the whole of your vision unless you have branch retinal vein occlusion, where only the portion of the eye that's blocked is affected. The portion of the retina that is containing the occlusion. And when you do fundoscopy, I'll show you a slide after this as well. So you're going to get this blood and thunder appearance. So if I can convince you that there is some blood and thunder on that image there in the top two quadrants. So you're going to get dilated, tortuous retinal veins, and then flame and blot hemorrhages, which is like the blood and thunder part of it. Retinal edema. I don't know if you can kind of see that in the center there. And cotton wool spots and hard exudates. And then I'll show you some more, so it can get confused with CMV retinitis, and then we've got some pictures to differentiate, but I'll just talk about the management quickly. So you can give anti-VEGF injections as well. And these are things like ranibizumab, aflibercept. I don't think you have to remember those. Just remember anti-VEGF injections. You can also have steroid injections or implants, laser therapy, and this is things like panretinal photocoagulation and macular grid photocoagulation. And this is all to stop the development of new blood vessels, particularly in the iris or retina, as it can further cause glaucoma, which we'll also talk about later. And then you can also do vitrectomy surgery, which is removing the vitreous gel and other debris that may have appeared there because of the occlusion, such as hemorrhage. So this is the two differentiating things. So on the left, we have central retinal vein occlusion and CMV retinitis. So if you can appreciate, on the left, there's a blood and thunder appearance. On the right, there is a pizza pie appearance, which is caused by cytomegalovirus. And this is an infection of the eye, particularly occurring in end-stage HIV, so severely immunocompromised patients. You can kind of differentiate this from the history, but if they're just throwing out this ophthalmoscopy slide, if I can convince you the right has more cheese, that's what gives it the pizza appearance, and the left is strictly the blood or tomato sauce, blood and thunder. So if that ever comes up, just remember the sort of darker blood is to do with central retinal vein occlusion. Next, we're going to talk about hypertensive retinopathy. So the reason hypertensive retinopathy develops is because of a few features that are in the blood vessels in the eyes. So they don't have a sympathetic nervous supply, they can't auto-regulate blood flow, and they have a presence of the blood-retinal barrier. So when you have an increase in blood pressure around other parts of the body, it's fine, but in the eye, the force of the blood pressure is directly transferred to the vessels, which initially start constricting. And then there's a few phases that occur during hypertension within the eye. So because of this like compensatory behavior, you're going to have some damage to the muscle and endothelial tissue in these vessels. So first you have the vasoconstrictive phase, and this is the initial response to elevated blood pressure. And there's some autoregulatory mechanisms in the eye which cause the vessels to vasospasm and narrow in the arteries. Then you're going to have the sclerotic phase, the exudative phase. That should be last, as that's sort of the later stage, but appreciating the sclerotic phase first, we're going to have some chronic changes with chronic hypertension. So these include vessel wall thickening and opacification. And then this is going to cause the arteriovenous nicking that you can see on the image here in the top left. And then the exudative phase, we're going to have leaking of fluid and blood into the retina. And this causes the hemorrhages, the exudates, and the cotton wool spots. And then if you look at the image with the black background, you can see all of those features there. So you got some blot hemorrhages in the top right, the sort of darker brown blood leaking out there, the cotton wool spots as well. Arterial narrowing, I don't know how you would tell sort of just on a fresh slide, but I guess they're narrower than they usually would be. Discodema, as you can see, that sort of central macular area is quite a lot wider than normal. And then the copper wiring is the sort of opacification of the walls of the vessels. Sorry, and then you can see that with lighter inside and the darker outside there. And then management, was focused on blood pressure control, as that's the cause of the retinopathy. And you're going to do things like antihypertensives, tell them to reduce smoking, controlling blood lipids, and what have you. Next, we're going to talk about glaucoma. I'm just checking the time. Yeah, that's fine. So to appreciate glaucoma, I was quite confused by this. I'm always confused with open angle and acute angle. And then they kind of cause the same thing, but they function in different ways. And one is a lot faster than the other. So to appreciate it, we just need to understand the trabecular meshwork a bit. This is a crucial tissue. If you can see on both of the pictures, they're on the sort of edge of the dome of the eye there. And what this does is it regulates intraocular pressure by controlling the drainage of the aqueous humor. So all the aqueous humor is going to drain through there. And then the fluid nourishes the cornea and the lens normally, but when there's too much, it can cause pressure and damage within the eye. So it's located in the anterior chamber angle, and it's like a sponge, I guess, that filters the aqueous humor, and it exits through the Schlemm's canal, which is sort of on the edge of that cornea there. So with open angle glaucoma, the way that the fluid gets blocked is there's a gradual increase in resistance to flow of the trabecular meshwork. So open angle is just because the trabecular meshwork can't properly filter out the fluid, and then you have pressure which slowly builds up within the eye. Whereas in open angle closure glaucoma, it's acute. Oh, sorry, I meant to say acute angle closure glaucoma happens a lot faster, and it's because the iris bulges forward. And then if you can appreciate on the right picture, it's blocking the trabecular meshwork. So there's nothing wrong with the drainage of the meshwork itself. It's just the iris that's bulging and preventing fluid from leaking out. And this is a much faster process. And once the humor is prevented from draining, there's a continual buildup of pressure and a very, very acute onset of symptoms. So that is an emergency that you need to get seen to immediately by an ophthalmologist. And in the bottom right image, you can see what that presents like a very sort of red eye. And the patient is unaware of this sort of 40% of the time. Until 40% of their nerve fibers are compromised. So it's a very sudden thing, and they're going to have tunnel vision as it starts peripherally. And then you might notice things like difficulty, just things with difficult vision, like problems bumping into things and getting around. So why is this like a problem, and how does the pathology sort of create the issue? So when you have raised intraocular pressure, it causes cupping of the optic disc. And then you can see this as well in the bottom left two images. So this is one of the criteria for differentiating the condition. So it's when the optic cup is more than 50% the size of the optic disc. So that will be the one on the left of the two images, where usually it's supposed to be less than 50%. That indicates a healthy eye, whereas the cupping of more than 50% is abnormal. So risk factors for open angle, you're going to have increasing age, family history, Black ethnic origin, and myopia, which is nearsightedness. Then risk factors for acute angle closure glaucoma is going to be previous ocular history. And this can be many things like just eye pain, redness, headaches, uveitis, cataracts, vascular occlusions, or pretty much anything, I guess. And then also African-American race, refractive errors, chronic use of topical or systemic corticosteroids, which you shouldn't really be using around your eye anyway, ocular surgery, previous trauma or recent trauma, and then certain medications can cause that as well. The medications that can cause, I don't think it's very important to know, maybe noradrenaline, but I think just for the scope of this teach, just know that there are medications that can cause it. In open angle glaucoma, as I said, they might get tunnel vision, and this is because of the peripheries being affected first. And how do you diagnose it? You have various methods, but you want to assess their vision And then you also want to assess the intraocular pressure. So you can do this with Goldman applanation tonometry. You want to do a slit lamp because that lets you visualize the cup ratio, as you can see in those images below. Visual field assessment will tell you about the peripheral vision loss. And then gonioscopy assesses the angle between the iris and the cornea. The signs, we did discuss them briefly, but in that image on the right, you'll get things like red eye, hazy cornea, decreased visual acuity, obviously, and then mid-dilated pupils, and they will be fixed. So the pupils are not going to change in response to light. And you also have a hard eyeball on gentle palpation, but I wouldn't advise you palpating someone's eye with glaucoma unless you're an ophthalmologist. The management. So for open angle, it's only really treated if you have a intraocular pressure of over 24 milliliters of mercury. And the options that you have are 360 selective laser trabeculoplasty. This is recommended by NICE since 2022 for all patients. And this just means a laser is directed at the trabecular meshwork, and that improves the drainage and allows the fluid to flow again through the meshwork. And this treatment is just good because eye drops are not really convenient, and you can't really convince a patient to be very compliant with them. They're quite a difficult thing to teach patients how to use properly, but we do have some available, such as prostaglandin analog eye drops. These are things like latanoprost, and this is a first-line medical treatment. So what this does is it increases uveoscleral outflow. Then you can use beta blockers such as timolol, which reduce production of the aqueous humor, carbonic anhydrase inhibitors, which also reduce the production of aqueous humor, and then sympathomimetics, which also reduce production of aqueous fluid and also increase uveoscleral outflow. That pattern of what the drugs do, quite confusing. That's just something that you're going to need to revise, but I would suggest doing that as it has come up in a few of my exams. And then last time we've got trabeculectomy surgery, which is required when all of those other treatments are ineffective. Obviously, you don't want to do surgery where it's not needed. Then for acute angle closure glaucoma, first we're going to lay the patient on their back with a pillow. And what this does is relieves pressure from the eye, and then it, I suppose it can potentially improve the flow of aqueous humor, but I think it's more for the pressure aspect and just getting the pain under control a bit as well. And what the way this works is it repositions the lens and the iris, and opens up the angle a little bit of the anterior chamber, just in the way that gravity like pulls on the eye when you're facing upwards. Then we've got some more eye drops. So we've got pilocarpine, then we've got acetazolamide, which is given either orally or intravenously. We've got some hyperosmotic agents such as intravenous mannitol, and some other things which are very specialist, but they're there in the slide, and I've included some of them in the notes as well if you want to read them later. And then last pathology I'm going to talk to you about is cataracts. So most cataracts that you'll see take years to develop. However, congenital cataracts occur before birth. And you'll notice these while testing the red reflex, as it will be absent. And you can also see the red reflex sort of in photographs with flash, as it will also be absent in people with cataracts. Some symptoms that you get are gradual vision loss. So because they develop slowly over time, except obviously congenital, the changes are not immediately noticeable, and people might not notice it themselves. It also becomes progressively blurrier, as it's essentially like a frosted window or a dirty window. So people might report blurriness. Difficulty seeing at night kind of comes with the territory of reduced vision, and people might sort of have a need for like brighter lights, like using reading lights more often, things like that. Sensitivity to light and glare as well. So lights can be too intense or too uncomfortable. You also get some halos and glare, so some bright rings, which you might see around lights, or glare, scattering, that kind of thing. Some color perception changes as well. And these changes are where colors may appear more washed out, or yellow and brown. I think some people argue it can also be blue or green that's washed out, but yellow and brown is one of those buzzwords. Yeah, and then people with cataracts may often change their sort of prescription for their glasses because their vision is reducing, but it's not because of the wrong prescriptions, because of the cataract. So there's lots of different types of cataract. Sort of more interesting to know. I don't think it's particularly useful for exams, but we've got some examples on the slide. So we've got congenital cataracts, which develop during birth or very early childhood. And this is due to genetic factors or infections during pregnancy. And you've got nuclear cataracts. These are cataracts which start from the nucleus of the lens, as in the name, and they spread outwards. And this is the most common type of cataract. Then you have cortical cataracts, which do the opposite. They start from the back of the lens near the posterior capsule. And these often cause glare more than other types of cataracts when reading in particular. Then you've got posterior subcapsular cataracts. You've got radiation cataracts. And you've got quite a collection of trauma-related cataracts. Some ones that I thought just are interesting to look at are electric cataracts. You've got this like snowflake pattern, and then traumatic cataracts there as well. Some diseases can also cause it. So myotonic dystrophy, atopic dermatitis, neurofibromatosis type 2, endocrine diseases such as diabetes, some drugs like corticosteroids can cause it. Poor nutrition can cause it. So deficiency in antioxidants and vitamins can lead to cataracts. And the usual alcohol and smoking also apparently contributes to it. For the management, there isn't really a necessary management if you're dealing with it. Okay, it's not like a dangerous disease, except it does lead to progressive blindness. But when you need an intervention, surgery is the mainstay. So there's two types. The most common one is phacoemulsification, or just phaco, and the other one is called extracapsular cataract extraction. So in phaco, it's making a small incision in the eye and then using ultrasound waves to break up little pieces of the cataract, and then it's all suctioned out. And this is just deemed the more safe, quick, and better version of the surgery. The other one is, and you can also have laser assistance with the phaco, which is quite cool. The other one is less common. It is sort of more used in less developed countries as well, but it's where the cataract is removed through just one large incision and it's just essentially scooped out. I think the complication rate is a lot higher with that one. But it's used for very advanced cataracts, or in non-developed countries where phaco is not available or suitable. And when you remove the cataract, you want to replace it with an artificial lens, which are made of silicone or acrylic. There's also different kinds of lens you can have inserted based on your vision needs. And then we've been asked to talk a bit about post-operative care. So these involve eye drops, rest after any surgery, shielding your eye so you don't want to expose it to obviously traumatic things like bumping into something, but also light. So you might have an eye shield. You do not want to drive. Your vision is not sort of safe for driving, and you want to avoid things that can cause contamination to the eye, like swimming, or just sort of any strenuous activity like heavy lifting or moving around in any capacity. No, obviously like walking around, but not like sports activities. You may also feel blurred vision and gritty feeling, which can result after surgery, and some light sensitivity, which would be helped by the eye shielding anyway. And then I'll pass over to Karen for our last pathology slide.
Yeah. So the last thing I want to talk about, and I'm glad I actually took this slide because it's something I wasn't very aware of beforehand, so that was good for me, is retinoblastoma. And this is essentially a malignant neoplasm originating from the retina. It is the most prevalent intraocular tumor in children. And moving on to the next point, it's why we actually test for the red reflex in children. So the red reflex test is like I said, carried out in newborns, essentially just shining a light onto the retina. That can be with your sort of ophthalmoscope or whatever, but you'll be shining a light onto the retina, and when this is reflected back off the retina, you should see a red light. If it's not red, if it's white, or if it's abnormal in some way, that could essentially suggest that there's a retinal problem, such as a retinoblastoma in that child. And the symptoms of that will be things like loss of visual acuity. That can be hard to test in children, but there are ways of doing it. Leukocoria is the name of this white reflection that you'll see. There's also a really important aspect of this, which is failure to thrive as well, because essentially if a child doesn't have their vision, they're not going to be able to go through the normal growing processes that they should do, really. And so they'll have problems related to that, and also strabismus as well. When it comes to management, essentially swift management and sort of getting rid of this is really important. One, because you're maximizing the child's survival chances, but also you want to try and reduce the burden this will have on the child as well. So there are some options. Generally speaking, radiotherapy, enucleation, chemotherapy, these sort of things are used to try and essentially get rid of the retinoblastoma. But unfortunately, they're not very pleasant procedures all the time. But what is good to know is that the 5-year survival rate of retinoblastoma is 90 to 95%. So it's, it will have an impact on the child's life potentially, but they will live on in whatever capacity that is. And hopefully most of the time, if it's diagnosed early on, they can do a lot about that. Okay. And in the bottom right, I've got some images as well, which you can see some of the changes you might see with retinoblastoma if you looked at the eye. So, got our poll questions, which I'll read these out. So, which of the following fundoscopic findings is most characteristic of central retinal artery occlusion? Oh, so we've got flame-shaped hemorrhages, we've got cherry red spots at the macula, cotton wool spots, and drusen deposits. Just give a few seconds to answer that one. So we've got the answer revealed to us there, Gabby, so you can close that one. Yes, the answer is, as you said, the cherry red spot at the macula. It's represented by the pale contrast between the retina and the fovea, and then you're going to get that very red spot in contrast to the pale retina. So the next question is, what is the most common symptom reported by patients with cataracts? We've got sudden vision loss, eye pain and redness, gradual painless loss of vision, or double vision in one eye. Okay, just aware of time. We'll close that one there. And yes, we already answered. Gradual painless loss of vision. So cataracts, unless they're congenital, cause a slow and progressive and painless decrease in vision. And that will be because of the lens opacity, which causes the blurred or decreased vision. We've got, which of the following best describes the typical visual field defect in glaucoma? Central scotoma, bitemporal hemianopia, peripheral vision loss progressing to tunnel vision, or superior quadrantanopia. Now we've got a very rapid responder there, but we'll call it there, and the answer is correct. Yes, it's peripheral vision loss progressing to tunnel vision, especially in open angle glaucoma, where it's a more progressive, slow type glaucoma. It prevents with peripheral vision loss, which then results in tunnel vision. And that's all the polls we have for you. And
the end of our presentation. So thank you very much for coming. And if you have any questions, please let us know in the chat, or do email us in any capacity afterwards. I think that will become available. Just got some SUPTA bits to share before we end.
So yeah, thank you for coming to our teach day. I think Gabby's back.
Hi everyone. Thank you so much for attending our teaching session. Sorry, give me 1 second. I'm on 2 meetings at the same time, so I apologize. Give me 1 second. Okay. So I'm going to be releasing the feedback now. I have released the feedback form, and I've also sent out an email. So please complete that for our tutors. They've done an amazing job today. Yeah, so the feedback form is available in the chat. Please fill it out and you'll receive your certificates and discount codes from Teach Me Surgery and pass the MRCS. Also complete the Google form for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. I am going to paste that in the chat now. Okay, that's in the chat. So yeah, please be sure to that Google form. And you'll get access to the Geeky Medics surgical flashcards, the OSCE stations. Our next session is going to be next week and is going to be on congenital surgical conditions. So please go to that. It's on Monday at 6:30 p.m. And we'd love to see you there. Please follow us on our social media platforms. The links for that are available in the chat, and you'll receive updates on our upcoming sessions via these platforms. Also, we will be posting SBAs on our socials for additional practice. And please visit our website where you'll find a resource bank with the materials, not just for this session, but all our previous sessions in the teaching series. They include summaries and a question bank featuring extra questions that aren't available on our social media. We hope you found today's session valuable and engaging, and thank you once again for joining us, and we look forward to seeing you in our next session. Are there any questions before we go? The recordings, so you can find the recordings on the Medal platform. I have to wait a while for it to upload, but I will be uploading it within the next few hours. Another message. Thank you. You're welcome. Please complete the feedback for our tutors. They've worked really hard on organising this for you, so it's really useful for them. How do you get the flashcards? So I don't actually know how they do it is a raffle. I'm not involved in releasing who wins that, but you have to complete the Google form, and I believe you're entered in to a raffle, and then you'll be notified if you've won. The notes should be uploaded onto our website. That is not a raffle. Okay, well, thank you so much, Karam and Tim. You have done an incredible job, not just for this session, but all your previous sessions as well. Thank you so much for all the hard work you guys have put in. You have been excellent tutors. And thank you for all of our attendees for joining. Again, please fill out the feedback, and hopefully we'll see you in some of our other sessions.
Thank you very much. Thank you guys. Thanks for coming.
Bye, everyone.